Hello, my name is Teresa Brannon, and I am the Manager for Training and Technical Assistance at the National Center for Health and Public Housing, a project of North America Management. I want to welcome and thank you for attending today's webinar, What's in Your Health Center's Inventory for Emergency Preparedness. This webinar is being recorded, and the slides will be emailed to you after the webinar has finished. And at the end of the webinar, there will be a question and answer session. I would like to say thank you to HRSA for allowing us to make this webinar possible through a publication grant number U30CS09734. And I'd like to get started with being honored to have as presenters Marcie Roth, who is the Director for the Office of Disability Integration and Coordination for the Department of Homeland Security and FEMA, and Derrick Williams, who is the Director of Security External Affairs at Brooklyn Plaza Medical Center. Marcie Roth was appointed by President Obama to the U.S. Department of Homeland Security, FEMA, in Washington, D.C. in June of 2009. She serves as Senior Advisor to Administrator Fugate and Director of the FEMA Office of Disability Integration and Coordination, managing a national cadre of over 70 disability integration advisors supporting implementation of objectives toward achieving the President's National Preparedness Goal and leading the national transformation towards integrating the access and functional needs of children and adults with disabilities across all aspects of whole community emergency preparedness and disaster response, recovery, and mitigation. Ms. Roth joined FEMA after serving for over 20 years in senior leadership positions with national and international disability policy organizations. She led national private sector response to the additional needs of survivors with disabilities during and after Hurricanes Katrina and Rita, and she was commended by the White House for her efforts on behalf of New Yorkers with disabilities in the aftermath of the 2001 terrorist attacks. Ms. Roth was recently deployed to New York for 291 days as a member of the Hurricane Sandy Joint Field Office Command Staff, managing a disability integration advisor team of 15 subject matters. When not on deployment, she lives outside Washington, D.C. Derrick Williams has been the Director of Security External Affairs for the Brooklyn Plaza Medical Center for 2 years. Prior to being at Brooklyn Plaza Medical Center, Mr. Williams was a security manager for Estee Lauder for a period of 1 year. These two positions came after a 27-year career with the NYPD. Mr. Williams worked in patrol services for 17 years, which included routine patrol, undercover operations, and training auxiliary police officers. Mr. Williams later headed the recruitment unit for the NYPD Police Cadet Corps, which provides paid internships for college students interested in a career in law enforcement. Mr. Williams later supervised investigators and instructors in the Applicant Processing Division. I am now turning this over to Ms. Roth.
Good afternoon, and thank you very much for having me. I really appreciate the opportunity to speak with a group of people who I consider to be vital partners as we consider the preparedness needs of the whole community. For those of you who are unfamiliar with Administrator Fugate, ever since he first came to FEMA, he's been very clear about the critical need for the full inclusion of children, people with disabilities, and the whole community to be integrated into all aspects of preparedness and planning. Administrator Fugate says, my experience tells me if we wait and plan for people with disabilities after we write the basic plan, we fail. And so early on after his appointment, he invited me to come on board, we established the Office of Disability Integration and Coordination. The role of my office is not to handle all disability matters, but rather to provide the kind of guidance, tools, methods, strategies to help everyone to integrate and coordinate inclusive emergency management. Excuse me. The President's National Preparedness Goal calls on us all jointly work to achieve a secure and resilient nation with the capabilities required across the whole community to prevent, protect against, mitigate, respond to, and recover from the threats and hazards that pose the greatest risk. The President's National Preparedness Goal and national preparedness is the shared responsibility of the whole community. This means that everyone has something to contribute, and that's not just the folks who have those job titles, but that really includes everyone, public and private, individuals and communities. And if we're going to successfully engage the whole community as partners in preparedness, this requires equal access to preparedness and recovery activities without discrimination. It requires that that we meet the access and functional needs of all individuals, and that we engage in consistent and active involvement of the whole community in all aspects of planning and recovery. You may or may not be familiar that there are quite a few laws that prohibit discrimination in emergency programs on the basis of disability. You may be familiar with some or all of them. The Rehabilitation Act plays a particularly critical role. I'll talk about that a little more in a few minutes, but you'll notice that I've listed each of these laws, and most of them are 20, 30, 40 years old. These are not new laws. What is new is that there has been more recent guidance, tools, resources for how communities can best meet the requirements of these federal laws and provide equal access to emergency programs. In particular, the Americans with Disabilities Act, as you may be familiar, prohibits discrimination on the basis of disability, not just in employment and state and local government, but also in all public accommodations, commercial facilities, transportation, and telecommunications. The individuals who are afforded the protections of the ADA are people with disabilities, or those who have a relationship or association with an individual with a disability. So what does that mean? What is the definition of disability? So the legal definition is a physical or mental impairment that substantially limits one or more major activities, a record of an impairment, or being regarded as having an impairment. It doesn't apply to impairments that are transitory and minor. So I'll talk a little bit more about that in a few minutes. Under the definition of disability, where it refers to major life activities, the list of those major life activities is very extensive. It includes, but isn't limited to, caring for oneself, performing manual tasks, seeing, hearing, eating, sleeping, walking, standing, lifting, bending, speaking, breathing, learning, reading, concentrating, thinking, communicating, and working. So when you think about the folks that you serve in your communities, many of them have the legal protections because of the impact on their major life activities. And then in terms of their major bodily functions, this list is also very extensive, including functions of the immune system, normal cell growth, digestive, bowel, bladder, neurological, brain, respiratory, circulatory, endocrine, and reproductive functions. So again, it's a very extensive list of people who have these protections. According to the U.S. Census, there are approximately 58.7 million Americans, 20% of the population, who have a disability. Over 11 million children over the age of 6 and adults need assistance with activities of daily living. And if you think about this from a more global perspective, there are a billion people with disabilities across the globe. So this is not some fringe group, even in the limited definitions that the U.S. Census has been able to capture. This is still a very large segment of the population. The Rehabilitation Act of 1973 is especially notable for both the federal government and any recipient or subrecipient of federal funds, because we are all required to make our programs accessible to individuals with disabilities. This applies to all programs and businesses that receive any federal funds, and it applies to all elements of physical or architectural, programmatic, and communication accessibility in all service and activities that are conducted by or funded by the federal government, and in our case specifically FEMA. But this is not limited to FEMA. This is all federal dollars. Section 504 of the Rehabilitation Act speaks very specifically, and Section 504 is a broad section of the Rehabilitation Act, and it essentially speaks to the requirement that people not be excluded from, denied the benefits of, or subjected to discrimination, again, under any program or activity that receives any federal funding. In addition to Section 504 of the Rehabilitation Act, you may or may not be familiar with Section 508. And Section 508 is specific to information or services from a federal agency that are comparable to those provided to the public who are not individuals with disabilities. So it requires that all electronic and information technology that is procured, developed, maintained, or used complies with accessibility standards. So what that means is that people need to have equal access to effective communication. These laws and the others that I listed earlier apply across the board, from your preparedness activities to exercises, notification, evacuation, and the transportation needs that people may have in emergencies and disasters, sheltering, first aid and medical services, lodging and housing, and transition back to the community, debris removal, cleanup, and virtually all other aspects of emergency preparedness, response, recovery, and mitigation. I've provided for you the Department of Justice definition of access. I've given you quite a few slides today that I won't have a lot of opportunity to spend much time on, but I did want you to have them, and I'm certainly available afterwards for any questions that you may have. You may or may not be familiar with the types of disabilities and health maintenance needs that the Census and the Federal Communications Commission have provided for us, and I want to make a particular note that data would indicate that while the numbers of people who have hearing, mobility, vision, speech, cognitive, intellectual, and mental health disabilities is high, and again, it's 20% of the U.S. population, those individuals who have health maintenance requirements is huge, estimated to be somewhere around 50% of the U.S. population. And this is particularly notable in emergency preparedness because we need to take into consideration what people will need in order to maintain their health, their safety, and their independence, because I certainly don't have to tell you that when people don't have the ability to maintain their health, the cascade of events that follows can have a life-altering or worse impact on both that individual and very limited community acute care resources. You know, while we talk about population in the aggregate, I think it's particularly important that folks have a clear understanding of what the actual demographics are in the communities that you're serving. And so I've put up a slide of the New Madrid seismic zone states. These are, of course, the 8 states around the New Madrid seismic zone that are most likely to be impacted during a catastrophic earthquake. So if you look at these states, Illinois, Indiana, Kentucky, Tennessee, Alabama, Mississippi, Arkansas, and Missouri, you will notice that while a number of those counties that are in green may have a population of people with disabilities that's somewhere under 20%, the vast majority of those counties have a population that is somewhere between 20%, and those counties in red would be a population of people with disabilities that's as high as almost 33%, which would be 1 in 3 people in those counties. Now, there's a whole host of reasons why that may be, and I don't have time to discuss it today, although I can imagine that in the work that you all do, you're probably at least as familiar as I am with what some of the factors are. But the bottom line is that in your local planning, it's critically important that your demographics are what you're working from. Because if you're planning for 20% of the population, and in a catastrophic event you actually have a much higher percentage of people who have physical, program, and effective communication accessibility requirements, then you're going to fall short. When we talk about disability, you will also, if you haven't heard the term, in the national frameworks and in many of our other documents, we're using the term access and functional needs because while there are many people who have the legal protections of these laws that I discussed earlier, there are many people who are going to benefit from the very same kinds of physical, programmatic, and effective communication access, even though they may not have those legal protections. And in emergencies and disasters, it's particularly important that we not simply focus on legal definitions, but rather we focus on the true access and functional needs of the whole community. So as you can see on this list, there are many people who are going to benefit from the very same planning considerations, even though they may not have exactly the same legal protections. And it's especially important, and again, I'm sure I don't have to tell you all, it's especially important that we consider that most people with access and functional needs, and particularly many people with disabilities, do not have acute medical care needs. And most live in the community on a daily basis. So when we, again, as I said earlier, take this into consideration in all of our planning considerations, we can not only assist individuals to maintain their own health, safety, and independence, but we can really optimize limited community resources, and we can optimize the outcomes for everyone in the community to be able to return to their pre-disaster level of independence. You will notice that we are no longer using the terms special needs and vulnerable. The use of those terms is confusing, and it does not help us to focus on what those specific access and functional needs are. When we talk about what people need to be able to have equal access, when we talk about what people's functional needs are in the areas of communication, maintaining independence, maintaining health, independence, safety, self-determination, support services, and transportation. When we address those, the margin of resilience significantly increases in communities. And then many people will say, well, what's in a word? Does language really matter? I would argue that, and I think Mark Twain said it better than I could, the difference between the right word and the almost right word is the difference between lightning and a lightning bug. If we continue to think of the access and functional needs of not just 20% of the population, people with disabilities, but a larger group with access and functional needs, if we continue to consider those special needs, then they will often become secondary, an afterthought, or not considered at all. Language drives behavior, and we need to move away from special or vulnerable and think in terms of community and each individual's opportunity to be a part of the planning rather than being the recipient of other people's efforts. So again, we talk about physical access, we talk about program access, and we talk about effective communication access, and there are many ways that FEMA is working with our local communities to achieve access in these particular three legs of the accessibility stool, if you will. Information has to be accessible to be actionable if we want people to take personal responsibility, if we want people to be able to maintain their health, their safety, and their independence during catastrophic events. People need to have equal access to information so that they can take action to protect themselves, their family, and potentially to also assist others in the neighborhood and in the community. I share this slide, the zombie attack survival kit, because I want to make the very important point that we can't just prepare for hurricanes or earthquakes or name the part of the country that you live in. We need to be considering all hazards. I don't, in fact, think we need to consider a zombie attack, but I think this is just a fun way of reminding us all that we need to be thinking about all of the kinds of things that might impact the community. And when we engage people with disabilities as partners, we move away from the sort of historical perspective that people with disabilities are a liability in emergencies and disasters, rather than giving people an opportunity to be full participants and to become assets or force multipliers in the community. At FEMA, we have moved towards making sure that our disaster recovery centers provide equal access, and here are some examples of some of the tools that we make available. I've given you a number of proactive community actions that we've seen as promising practices. Again, I'm not going to spend much time on those today, but they are in your slide deck. We also have many resources that we've been providing to communities. We have disability integration specialists in every region, and we now have a disability integration advisor cadre that is available for deployment upon state request during and after a disaster. We've also published the allowable grant expenditures that states can prioritize in their planning and purchasing, utilizing Homeland Security and other emergency support grant funds. One of the areas that we've been putting a lot of our focus is on the issues of people who require power to maintain life-saving or life-sustaining level of functioning. And we recently brought together a group of Hurricane Sandy survivors who use ventilators, and have really been listening to them. They're the real experts on preparedness, and we're excited about some of the lessons that we're learning from them, and look forward to sharing more of that information moving forward. Don't know if space weather is on your radar. It's something that we spend a lot of time thinking about in terms of the potential impact on technology, and so in my role I'm particularly concerned then about the impact on technology that people with disabilities use. You know, there's many things to be cognizant of in our planning, and the potential impact of space weather is just one more of them. And so as you participate in exercises, it's critically important that community members with disabilities are actively involved in those exercises. And these are opportunities to pose real-life challenges. Evacuation needs to take into consideration the evacuation requirements of people with mobility disabilities, people who are deaf or hard of hearing, and really the needs of the whole community. Accessible transportation is a critical element of successful evacuation. People need to stay with their equipment. If we separate people from their equipment, their level of independence will be significantly detrimentally impacted. General population shelters need your help in the planning so that people with disabilities can receive the kinds of supports and assistance that they require in order to be able to shelter along with the rest of the community. Hospitalizing people or placing them in segregated shelters increases the requirement for paid medical help and decreases that health maintenance and independence that people can otherwise maintain if they have that support that they need in a general population shelter. And so we've provided some key concepts around that. We've also published guidance for local planning, and I've provided these links at the end of my slides. We have made available to states a number of contracts that during a presidentially declared disaster, states can request our personal assistance services, durable medical equipment, and consumable medical supplies contracts. In the personal assistance services contract, we can provide people who can assist individuals in general population shelters and temporary housing. During Hurricane Sandy, the state of New York requested our personal assistance services contract. We have the ability to provide up to 2,000 personal assistance service providers to a state upon request. As we look at housing, the accessibility requirements of disaster survivors with disabilities must be considered in all aspects of temporary and longer-term housing. And as well throughout recovery, it's critically important that disability community leaders and people who are involved in disability services and advocacy are engaged throughout the recovery process. And this requires partnership. And so, for example, the independent living centers, of which there are 450 of them across the country, need to be very much engaged as your partners, and can be wonderful allies in preparedness, response, recovery, and mitigation. There's a saying in the disability community, nothing about us without us, and this is critically important that in all aspects of preparedness, that people with disabilities are at the table, that planning is with and not for people with disabilities. And our disability integration specialists across the country can help you to make those kinds of connections if you don't already have them. Where do you fit in? We really appreciate the very critical role that you all play in your communities during steady state and as well in those times of catastrophic events. And your leadership, your knowledge of public health, your knowledge of your communities and the needs of your people are particularly important to helping emergency management to understand how to adequately prepare to meet the access and functional needs of the whole community. And when we do this well, when communities integrate the access and functional needs of children and adults with and without disabilities in all phases of community-wide emergency management, they strengthen their ability to prepare for, protect against, respond to, recover from, and mitigate all hazards. And this is a picture of my New York City team, Disability Integration Advisor team in Times Square while we were doing our Hurricane Sandy response and recovery work. Here are some links that you may find helpful. More links that may be helpful to you. Here's where you can find me. And I really appreciate the opportunity to spend time with you all today, and I'll be available afterwards for questions. Thank you.
Okay, good afternoon, everyone. My name is Derrick Williams, and I am the Director of Security and External Affairs for Brooklyn Plaza Medical Center. If I could have my, let's see here, okay. I would first like to state that we have developed a community, we as Brooklyn Plaza Medical Center, we have developed a partnership with the community. We serve the underserved. We have many patients here that are not covered by any medical insurance. We have many elderly people that come in and they need assistance getting in and out. Some of them come with assistance, some don't. We also offer a sliding fee scale for those people that do not have benefits. So we truly, truly help the community. I want to talk to you about our fire safety and our emergency disaster plan. And, okay, we are a federally qualified healthcare facility, and we have facilities at 3 separate locations. Our primary facility is at 650 Fulton Street, Brooklyn, New York, and that's where the majority of our staff is employed. We have a secondary facility. It's called the Whitman Ingersoll Farragut Health Center, or WIFHC as we call it, and that's at 297 Myrtle Avenue in Brooklyn, New York. And we also have a school-based health center, and that's inside of Benjamin Banneker Academy. That is a high school at 77 Clinton Avenue in Brooklyn. And all 3 of our facilities basically serve the same community. They're all located within 1 square mile of each other. We have several medical providers. We have 5 family practice providers. We have 4 pediatric providers. We have 3 OBGYN providers, 2 internal medicine providers, 1 who actually specializes in HIV healthcare, and we have 1 dentist. Within the next, I would like to say 6 months or so, we would also like to add 1 or 2 podiatrists, and we also will be taking our dental services over to our school-based healthcare facility as well. With the school-based healthcare facility, it doesn't act as a normal doctor's office. The only people that can be involved or attend or use the school-based healthcare facility are the students that are enrolled in the school. And once they're enrolled in the school, then their parents can choose to enroll them in our healthcare facility. And basically what it does for them is One, the facility acts as a nurse's office for the school, because since we're there, the school no longer has a nurse's office. We are it. But also, we actually take care of physical examinations for the people that want to participate on the athletic teams and so forth. All right, I want to talk to you about fire safety. Each employee is trained in fire safety at our semi-annual staff meeting, and each employee receives our employee handbook when hired. Our employee handbook actually has the passage pertaining to fire safety inside of it. The general fire safety rules are included in the handbook, and also included is a complete listing of the fire extinguisher locations, the fire alarm pull station locations, and the emergency codes. And each employee is instructed to peruse this occasionally, not just one time when they get it, but to peruse it occasionally and kind of take note of where all the fire extinguishers are in the building as they travel around the building, also where the fire alarm pull stations are. This way, if there's an emergency, they won't have to look for it. They'll kind of know, and they can just go to it, and they can do what's necessary. All fire extinguishers are inspected monthly and replaced yearly. And if the fire extinguisher is found without a tag, the facilities director must be notified immediately, and he will see to it that it's taken care of. Whomever the first to notice a fire will announce code red over the intercom and state the location of the fire. And what they're going to do is they're going to state the location of the fire, they're going to state code red, and they're going to state it 3 times over the intercom. And once they do that, then the director of security has designated members of the staff, as well as others, to be fire marshals and assistants. And what's going to happen is the security staff will assess the situation. They'll go to the location, they'll assess the situation, and the fire marshal and the assistant, they will go to the area where the fire occurred, they will turn off oxygen tanks, they will close all corridor doors, and they will immediately begin monitoring the area to ensure that evacuation is taking place, and they'll stay to ensure that it's complete if possible. One thing that I like to stress is we do not use elevators during emergencies. We do have an elevator in our primary location. We also have an elevator in the school. The school actually does not go by Brooklyn Plaza Medical Center safety rules because they are guided by the Department of Education, by the New York City Board of Ed. So the school has its own rules, and our staff in the school has to be guided by the rules of the school. The school also does not have to have our security staff present because all New York City schools have NYPD school safety members present. So Benjamin Banneker Academy probably has about 4 NYPD school safety members present at all times, and our staff is to be guided by them as well as the rest of the school. But for our locations at 297 Myrtle Avenue and 650 Fulton Street, they have to be guided by our rules. Okay. The fire marshal will advise all personnel that an order to evacuate has been given, as well as sounding the alarm, which means exit immediately. The medical staff is going to jump in, and the staff positions an area of the fire should help evacuate patients to the nearest available exit. And at each of our 2 locations where we have 2 security staff, our buildings sit almost on a left corner. So they face the main street, and they're very close to the left corner. At our primary location, we have 2 exits that exit to the front of the building, and we have 1 exit that exits on a side street. So at 650 Fulton, our fire exit on Fort Greene Place. We have another one that exits onto Fulton Street, and we have our main entrance and exits onto Fulton Street. At 297 Myrtle, the main exits onto Fulton Street, and the rear door, actually it's a side door, it exits onto North Portland Place. So everyone is instructed, everyone that's employed here is instructed to, if you go out one of the front doors, you make a right and walk away from the building. You walk at least 100 feet away from the building. If you go out the rear door, you make a left and walk at least 100 feet away from the building. And it's the same way at 297 Myrtle Avenue at our WIP site. If you go out the front, you make a right and walk 100 feet away from the building. And if you go out the rear, you make a left and walk 100 feet away from the building. with, we are actually part of a 6-site location. We rent one space of 6 sites of the same building. So we're the second door off the corner, and when they make a right, they actually have to walk past the other businesses and then walk 100 feet away from the building, because all the businesses are connected within the same building. So they have to move away from the building. Okay. The nurses aides, and the medical assistants should ensure their patients are dressed if feasible and escort patients to the nearest available exit. All other personnel will remove from immediate danger any patient in close proximity to fire or smoke, monitor the patient, and evacuate them in an orderly manner. Turn off all oxygen systems and remove oxygen cylinders from within the immediate area. They will also close all doors as they pass them. No one's going to go looking for doors to close. As you pass a door, close it. They close all doors to prevent the spread of fire and smoke. And they will also obtain a fire extinguisher and attempt to put out the fire if able. One other thing that I like to say about exiting the building, one thing that I stress to my staff is stay calm under fire. And under fire could mean anything. Stay calm, because generally most people are not inherent leaders. Most people are going to follow the lead of whoever they feel the leader is. So if my staff is leading them, my staff has to keep a cool head. Also, as people leave the building, the reason that I have them making a right when they go out the front and a left when they go out the rear is because I want to avoid anyone in an emergency crossing a street. Now, sometimes people do panic, and sometimes people, especially if they see that it's a true emergency, they leave in a hurried fashion. And sometimes people may not be paying attention to what's coming up and down the street. Our business is on very, very busy streets. Fulton Street is one of the primary arteries that run through North Brooklyn here, and it's very busy, a lot of buses, a lot of cars. And our goal is to make sure that people stay on the sidewalk as they walk away from the building. This way we don't have one emergency and create a second, okay? So that's something I wanted to stress. If the fire is in your area, use intercom stating code red and announce the location of the fire, and that's to be done 3 times. Escort visitors and public to the nearest exit. Close all doors and windows to prevent the spread of fire and smoke. Obtain a fire extinguisher and attempt to put out the fire if able, and evacuate the area. Again, my fire marshals are going to double check each floor if possible. They're going to make sure that everyone has evacuated. It's a lot easier in a drill than a real fire, but that's their job, and they will make sure that they do it. Okay. Next, the all clear signal. The purpose of this signal is to notify all personnel that the emergency has ended. All patients may be returned to their areas, and all procedures may return to normal. The all clear signal must not be sounded or actuated until it has been authorized by the administrator in charge and by the chief of the fire department. Fire prevention. High hazard items. Flammable liquids such as ether, acetone, xylene, benzene, etc. should be covered at all times and stored in approved self-closing metal containers. Very, very important that they're self-closing metal containers, because fumes are definitely flammable. The vapors from these items are highly flammable. Paint should be covered and stored in approved cabinets and locations as well. Storage in corridors and exits is unlawful, and that's not just storage of things that are flammable, but storage of anything. Storage of garbage, storage of old furniture, storage of ladders. All corridors should be clear of debris or blockage. Never block open doors with wedges, wood nails, etc. Never lock an exit door. Never use oil or grease near oxygen, and do not store oxygen with flammable gases. Do not discard pressurized containers, spray cans, or other cans. Empty oil containers and like material with burnable rubbish. When oxygen is being administered, no flames or machinery that sparks should be in the immediate area. No use of rubbing alcohol to introduction of any other flammable items to the area. is permissible. Smoking. New York City law prohibits smoking in all healthcare facilities. Our staff is actually instructed that if they observe a patient, visitor, or another employee smoking within the building, they have to advise them that it's in violation of the law and also the policies of the center. If the person refuses to put it out or refuses to leave with it, then they notify security, and security will deal with them. This is an example of what the employees receive in their handbook. It's all of the fire extinguisher locations on the first floor. So, you know, if you work in the building, you're very familiar with where these rooms are, and that's just on the first floor. These are all the fire extinguisher locations on our second floor. And these are the basement, the roof, and that gives you the total. And we also keep a couple of spares behind security desks. This way, if anything breaks out and one of us is not close to a fire extinguisher, we can always grab it and run with it. Next, again, in our employee handbook, is the pull station location. So if you happen to see something on fire, you can just run to the pull station, pull it, and what will happen is it'll sound the alarm, and then that same person should make an intercom announcement, and security should respond. Also, whenever a pull station is pulled, the fire department will automatically be notified, and they will automatically respond. One of the things that we do is when we do our quarterly fire drills, we have to make sure that we call the fire department in advance to let them know that they don't have to respond, because when we do our fire drills, we do sound the alarm. So we also do not take into account what the weather conditions are when we do our fire drills. Generally, they'll be pre-planned, maybe a day or two in advance, and it doesn't matter what the weather's going to be like. If it happens to be 2 degrees, if it happens to be snowing, raining, so be it. If it's a planned day for a fire drill, we will have our fire drill that day. Okay, and this just lets you know all the different locations where they are. And this is a list of our emergency codes. And code 99 is for medical emergency. Code red is fire. Code yellow is security. And of course, the overhead paging system would be used to announce any necessary code. And the code and the location should be repeated 3 times in a clear voice. Emergency disaster planning. When we talk about disasters, the one thing that we have to know is someone must initially recognize the disaster or potential disaster, whether the origin of the disaster is on-site or external. It could be the type of thing that's on-site, or it could be the type of thing like the World Trade Centers, where you either see it on the news or you hear about it from someone coming in, and we have to prepare ourselves as quickly as possible. It could be an earthquake, which actually happened here 2 years ago, summer of 2011. What we want to do is we want to communicate. As soon as the disaster or potential disaster is recognized, the phrase code yellow and the location of the disaster should be communicated over the PA system. This will alert security to respond. And security will respond, research, and assess the situation and obtain the most accurate, pertinent, and objective information. Confirmed disasters will result in a coordinated effort with the New York City Fire Department, NYPD, the Department of Health, as well as Chicanes if necessary. And if anyone is unfamiliar with what Chicanes is, that's the Community Healthcare Association of New York State. And Chicanes is actually very, very important to community healthcare centers like Brooklyn Plaza Medical Center. Annually, we team up with Chicanes, and we do a disaster drill. It's a multi-pronged disaster drill. And for example, this year, the drill was they come in, and I think they came in with maybe 6 or 7 actors, and they kind of perform a multi-pronged attack, if you will. And what they do is they'll go, when you come into our center, to Brooklyn Plaza Medical Center, you have to go past the security desk to get to the elevator. And, you know, it's a short ways away, but you go to the elevator, you get off the elevator on the 2nd floor, and you go to what's considered our front desk or our reception area. And the way that they did their multi-pronged attack was they had several people come in with lesions painted on their skin. They had people coughing, and of course our staff has to react in the proper manner. They have to provide treatment, they have to isolate, they have to do all the things that are necessary as per our guidelines. Also, at the same time, we had an irate parent come in. It was a father whom found out that his daughter was given birth control by our facility. And this gentleman happened to be intercepted by security. And it depends on how things go. He just happened to not make it upstairs that particular day, but everyone else did. And not only is Chicane's helping us with this, but they're evaluating us while we're doing it. So if we make any mistakes, if we act improperly, then they write up a report and they tell us what we've done wrong and how we can change it, how we can improve it. Decisions will then be made based on the type of disaster that has occurred, or for certain types of disasters, such as dangerous spills, and usually that would be internal. The area where the spill occurred will be evacuated and the spill isolated, contained, and cleaned. Combustible situation will result in evacuation of the building. Irate or potentially dangerous patient or disgruntled employees will be isolated while safety precautions are taken. For evacuation, employees as well as patients will exit the building and travel a safe distance, minimum of 100 feet. I talked about that before. You go out the front, it's the right. You go out the rear, it's the left. If exiting main entrance, make right onto sidewalk. If exiting rear, make left onto sidewalk and travel 100 feet no matter which way you go out. Once the situation has been assessed and rectified, instructions will be issued pertaining to possible re-entry into the facility. Brooklyn Plaza Medical Center does not routinely handle emergency cases and therefore is not adequately equipped or staffed to efficiently serve as a medical resource in the event of a major disaster. If you paid attention to our provider list, we do not have an orthopedic doctor on our staff. So we don't deal with broken bones. We don't have imaging at our location. Because we do have OBGYN, imaging is outsourced. So anything, our internists, if they need to send anyone for any kind of imaging, our OBGYN need to send anyone for a sonogram, then all of that is outsourced. And then the doctors receive the images once they're taken care of. Well, we do not do x-rays on site. We do not do any kind of imaging on site. And they do not repair broken bones here. Okay? If an event that could be classified as a disaster occurs, the physicians and nurses are instructed to offer any assistance necessary as may be requested by the fire emergency team or police department. And if any injuries are deemed too serious to be treated at BPMC, the patients shall be triaged on site, pending transport to Brooklyn Hospital. We do have a partnership with Brooklyn Hospital. Actually, our chief medical officer at our location is an OBGYN at Brooklyn Hospital as well. So we do partner with them in a couple of different ways. One I'll get to a little bit later when we talk about possibly losing electric power. BPMC's main site is located less than 2 blocks from Brooklyn Hospital, which is identified to receive and treat large numbers of casualties regardless of the level of injury. Outside disasters may lead to an influx of emergency patients. If an outside disaster occurs that does not lead to an evacuation, the patient waiting area may be used to triage the injured or ill while they await treatment. If necessary, BPMC may make use of the covered parking lot. One of our parking lots at our primary location is covered, as well as available tents for triage while awaiting treatment or transport to Brooklyn Hospital. For disasters that do not permit BPMC to open for business, each member of the executive staff possesses a complete contact list of all employees in the organization. In these cases, BPMC utilizes a conference call line, and the entire executive staff shall conduct a conference call each day until the center reopens. Each member of the executive staff will be responsible for updating his or her team with all pertinent and necessary information. And this is very important. It actually was one of the things that worked for us during Hurricane Sandy. We ended up being closed for 3 days, 3 work days. We were actually closed over the weekend as well, but we were closed for 3 work days. And the reason that we were closed is not because we lost power. We were closed because so much of the city was shut down that people couldn't travel. Obviously, a lot of people had trouble getting gasoline, but the subways weren't running and the buses weren't running either. So it would have been impossible for us to run our center without people being able to get to work. So until things kind of started to get back to normal, then we had to shut down our facility. In the event of the loss of electrical power, an agent of BPMC, and the agent would be either myself or my staff, will transport all vaccinations to Brooklyn Hospital for refrigeration. Brooklyn Hospital possesses electrical generators which allow full operation of their facility in the event of power loss. And this is another thing that's very important. At 2 of our 3 facilities, we do house vaccination. And fortunately, the 2 facilities are very close to each other. The way that we check to see if our power is down without actually having to come out initially is our IT person. He checks to see if he can access the server. And he continually checks to see if he can access the server. You know, he might check once every hour or so during an emergency. And if it comes to a point where he can no longer access the server, then he notifies me, and either myself or one of my team will come, open up the location, or we'll come and check to see if we actually have power. And if we still have power and we see that everything's okay, you know, then we don't have to worry about transporting a vaccination. If we don't have power, we transport them to Brooklyn Hospital. And as I said before, we have a limited partnership with Brooklyn Hospital. They are expecting us in case of an electrical shutdown. Okay, that ends my show. That ends my presentation, rather. And I just want to say that I thank all of you for being a part of it. I thank all of you for listening. We're all an integral part in healthcare in America here. Thank you very much.
Thank you, Derrick Williams. That was a really great presentation, along with Marcie Roth. That was a wonderful presentation. If there are any questions, please just either you can raise your hand, the raise your hand icon, and we'll unmute you and you can ask a question, or you can type in your question and send it through, and we can ask questions of Ms. Roth and Mr. Williams. I do have a question. I believe this one would be for you, Mr. Williams. When you evacuated the facility, do you consider relocating your patients and staff on the downwind side of the fire, smoke, chemical? And do you utilize an alternate location written in your plan?
What happens is if we have anyone that needs emergency medical care, we notify Brooklyn Hospital, we call for an ambulance or an ambulette, and they get taken over there. And as far as actually, we try to take them down. If there's a fire, we don't try to use the exit closest to the fire unless the fire is actually away from the exit. Sometimes the way I exit, they're at opposite ends of the building. So the fire could be in between them, at which point we could use both exits. I did state also that we do not use the elevator, and we do have people that are here in wheelchairs and so forth. And we have our staff carry the people down the stairs, and we bring the chair down and we put them in the chair.
Okay. Ms. Roth, this question is for you. Does FEMA coordinate emergency preparedness plans for people with disabilities with state health departments? And if they do so, who's in charge in case of an emergency?
It's a great question. FEMA, through our emergency support functions, works very closely with the Department of Health and Human Services and their emergency support function number 8. And so we work very closely throughout the year with the Department of Health and Human Services, and then both federal agencies have both regional representatives who work with the states in their regions.
Okay, great.
Does that answer the question?
Yeah, that does answer the question. For Mr. Williams, this question is to you. Do you evacuate patients when you do a fire drill?
Yes, we do. Everyone leaves the building. The only person that will be left behind is my facilities manager, and he's the person that actually controls the alarm. Everyone else will leave the building, including myself.
Okay. Okay. And
including the doctors as well.
Okay, great. And Ms. Roth, this question is for you. How can a community health center include people with disabilities in an emergency preparedness plan? That is, how can they be an aid and not a liability?
Oh, that's a great question. So I would strongly encourage that you reach out to your local disability services and advocacy organizations, most particularly your local independent living centers. There are independent living centers in almost every community. Your aging and disability service centers as well are great local partners, and these local resources tend to be great hubs for the progressive disability service systems, and that's where you're going to find folks who are probably best qualified in the area of disability inclusive emergency preparedness.
Okay, great. That's great.
And if you would like to reach out to your local independent living center, you can go to the website for the National Council on Independent Living. That would be ncil.org, and you can find all of the independent living centers there.
Okay, great.
Or many of them. Not all of them, but you can find many of them there.
Okay, thank you. This question goes to Derrick. Have you thought of using evacu chairs rather than physically carrying someone down the steps? Assuming it's not a fire but some other disaster, this can be traumatic for the individual, especially if there's not a wheelchair at the bottom of the steps.
We actually have thought about it, but because we are we're a two-story facility with all of our offices on one story, and at our location over on Myrtle Avenue, that's a one-story facility, so we don't have to worry about carrying them down the steps. We do have 4 steps in the back at that location, but we do have a ramp for the 4 steps there. What happens here is, because we have limited space, we don't really have storage space for an evac chair. So, you know, my staff, you know, they have strong backs, and we just make it work.
Okay. Thank you. And then, Ms. Roth, this question is for you. If a facility is closed due to any kind of disaster, is it up to the facility for them to reopen, or does FEMA, do you get involved in the process of them reopening just for safety issues?
That would not be FEMA's role. FEMA works in support of the state, and your state health department or your state emergency management agency might play a role with you all, but it would not be FEMA.
Okay, great. Okay, that's all the questions.
If I could add one more thing.
Sure.
FEMA may, in fact, the individual facility may be eligible for public assistance grants for the purpose of repair after a declared disaster. So FEMA might fund repair, but that would not it would not be FEMA's role to be personally involved in any sort of rebuilding.
Okay, thank you for that clarification.
Sure.
Let's see. I just wanted to say thank you to Marcie Roth and Derrick Williams for their time and their expertise on this really very important topic, especially what has happened in the the past years with the Derecho that came through, and Hurricane Sandy, and the tornado that came through Oklahoma. We absolutely need people like you to keep us abreast of important planning for emergency preparedness. To all the attendees, please complete the post-survey. This helps the National Center for Health and Public Housing to improve our webinar presentations for you. If you have any training and technical assistance needs, please contact one of our talented staff members for assistance. And once again, thank you very much to all that have attended the webinar, and to Marcie Roth and Derrick Williams, thank you very much for your time.
Thanks for having us. Appreciate it.
Thank you.